placing a dissection stent first and then doing an angiogram and seeing, what's perfusing. And I haven't, rarely, I would say, there still are cases where you have to place a stent in a renal, to maintain perfusion after the dissection stent.
Any additional questions? All right, well, thank you so much.
Next up, we have Dr. Darren Schneider, Chief of Vascular Surgery at University of Pennsylvania. He was talking about, I believe, upper versus femoral access for complex thoracoabdominal endovascular repair.
Thanks. Great to be back here. These are my disclosures. I don't know if any of my fellows are here, but it doesn't matter how complex a case we're doing. We can't not think about the access. And access, you can do a great case, you can high-five each other at the end of the case, but lo and behold, the patient can all of a sudden become hypotensive and arrest because you screwed up the access. So you can snatch defeat very easily from the jaws of victory if you don't concentrate and think about your access very carefully. I'm not going to go through all these specifically, but there are a lot of considerations in terms of planning your access, and this should be a part of planning every complex case is planning the access as you do the other parts of the case. In discussing upper versus lower extremity access, certainly there are some benefits from upper extremity access. It can be easier for downward going branches and downward going visceral artery targets. It enables you to do sequential deployment and to use certain preloaded devices that are accessed from above. Also, when you're working from above, you can restore perfusion to the pelvis and lower extremities earlier by removing sheaths. And it allows for through-wire access, which is sometimes useful for challenging cases. But really, the steerable sheath technology has been a game changer. So we've gone from having to use upper extremity access to being able to use it selectively. And really, this has enabled us to attack and access downward going branches and do it all from femoral access, so we don't always have to have upper extremity access. The concern with upper extremity access, besides adding to some complexity, is that there's a potential for perioperative stroke because you're traversing the aortic arch and the supraaortic trunks. And if you use entirely transfemoral access, you may decrease the risk of embolic stroke. You have improved ergonomics. You're not working all around the table. Decreased radiation exposure and shorter operative time by eliminating certain access points. We looked at this in the U.S. ARC consortium, looking at our upper extremity versus entirely transfemoral access, and showed that transfemoral access has a twofold lower rate of perioperative cerebrovascular events compared to those cases where upper extremity access was used. Not very high rates, but still significant, I think, 1.2% versus 2.8%. And our conclusion was that transfemoral access should be used preferentially in most patients. However, there certainly is a role for upper extremity access in selective patients. This is the technique that I use for accessing branches when doing BVAR coming from a femoral approach. This is some illustrations from Gustavo Oderich. He has a great illustrator that I don't have, but I use the same technique. And so we use an 8.5 French steerable sheath, usually a tour guide. It's introduced through a 12 French dry seal sheath. We have a 014 through wire that supports that steerable sheath so that you have a really secure foundation so that you can really advance things into the downward going branches. And through that, we telescope a 6 French by 90 Ansel sheath. A destination sheath won't fit inside the tour guide. And within that, we also, in our coaxial system, have a 5 French Berenstein catheter that we're using to select the target visceral arteries in the branches of the graft. And here you can kind of see that setup. You can see we've got the 12 French dry seal, the tour guide going through that. There's the Berenstein getting into, in this case, target superior mesenteric artery. We then telescope the 6 French sheath over the Berenstein so we can do angiography to mark where we want to land the stent, and then you saw the completed angio run there. But the reality is that we can't do everything from transfemoral approaches. Some cases are just better done from above, and you can see some examples here in patients that I've treated with extreme tortuosity or angulation of the perivisceral segment, kinked stent grafts or iliacs, severe occlusive disease, or all of the above can make things difficult to tackle from below. Here's some examples of small diseased access where you're not going to be able to do these cases entirely from below. And in the middle and the right-hand panels, you can see the staged deployment technique, where if you have some limited luminal space in that perivisceral segment, you can keep the bottom end of the graft constrained within the sheath, creating more room to navigate and get into your target visceral arteries before completely deploying the graft. And if you want to use this technique, you have to have upper extremity access to be able to do this. We've gone entirely to percutaneous axillary access when we use upper extremity access for complex EVAR cases. We have a pretty good experience, and we published our experience last year with 145 patients using percutaneous axillary artery access for complex EVAR. Most of those we deliver a 12 French sheath from the axillary approach. We had a 2% overall incidence of stroke at TIA in this series, and about a 7% incidence of closure failure that we treated with placement of self-expanding covered stents, specifically Viabon, at the access site. And if you look at those axillary arteries, we've had no loss of patency in those axillary arteries that were accessed or where we had to place a Viabon stent. And certainly, I think the benefits of going percutaneous versus open upper extremity access is you have shorter OR times, you have less blood loss. The axillary artery is a larger artery than the brachial artery if you're accessing more distally, so you really have flow around your sheath and you don't have arm ischemia, and you're also closer to your target, so you have a shorter working distance when you're doing this. I'm going to show you now the specific technique, and I think to be successful, you really have to adhere to these principles, which I sort of learned the hard way, kind of inventing this technique and then by trial and failure finding out how to do it well. Most important thing to start with is that the arm has to be out at 90 degrees. You can't have the arms tucked. It straightens the axillary artery and makes the access much easier. We always use ultrasound guidance when we use micropuncture, and we use a more shallow angle to access the axillary artery than we do with the femoral artery because it can be mobile and it is a little bit deeper, and this facilitates tracking devices and catheters into the artery. We access the second segment of the axillary artery, so we actually puncture through the pec minor, and I found that this is really the best place and safest place to access the artery. There, the artery is easily compressible against the second rib so that you can maintain hemostasis while you're doing exchanges, and you can find a spot that's free from brachial plexus or other structures anteriorly so that you can access the artery there. This is the ultrasound view that you want to see. So you can see on the transverse view here the axillary vein and the axillary artery. You can identify the pec major and the pec minor. And what we really want to see is when we push down on the ultrasound probe that the muscle is right against the artery, and then we know that there's no nerve or other structures in the way for our access. I use a stiff glide wire for my pre-close technique, and we do the standard pre-close technique with 2 per-close devices. And if you're concerned about whether or not your devices are tracking nicely in the artery, step on the floral pedal and watch it and make sure that things are going in smoothly and not buckling. We establish through-wire access before we deliver the large sheath, and then once we have through-wire access, we can really safely use this push-pull technique to smoothly and atraumatically advance that 12 French sheath into the aorta. Equally important is how you do your closure and get out of it at the end. So you have to have an exit strategy. So generally, we are working over through wires. So at the end of the case, we'll telescope a 7 or 8 French 90 centimeter long sheath from the femoral access over that through wire up into the 12 French axillary sheath. Then we'll withdraw that axillary sheath back once we've brought that femoral sheath up to the subclavian. We'll then wire both directions so that we have safety wires going both directions. We'll then tighten the per-close suture, still leaving the wire in place. We can do angiography through the femoral sheath to verify that we're going to have a hemostatic closure. And once again, I've pointed out here that you have to put the arm back out on the arm board and have it at 90 degrees when you're doing the closure as well if you want to be successful. Again, can't have the arms tucked to do this. And then after we know that it's going to be a hemostatic closure, we'll remove the wire through the axillary puncture site, retighten and lock our per-close sutures, and then verify again with angiography that we have a hemostatic closure and no issues. A lot of times we have these patients anticoagulated. You can have a lot of oozing from the sites. I routinely use this technique that Ali Azizadeh had published several years ago, where we put either a piece of tubing or a Ramel tourniquet over the perclosed sutures, and that kind of provides a little tamponade, additional tamponade to get hemostasis. So there you can see in that last picture I showed you, there's the little clamps on the Ramel tourniquets that we're also using to aid with the hemostasis. And we actually use these pediatric Ramel tourniquets that work very easily, and then we don't have to cut the side arms off of sheaths. Certainly there are cases when you absolutely want to avoid upper extremity access. I think most of this is pretty obvious: shaggy aortas and extreme tortuosity up in the arch. Again, just to reemphasize some of the important tips, when you're getting your access and when you're exiting at the end, the arm should be abducted to 90 degrees. We have a articulating arm board so that we can have it out at 90 degrees, and then when we're done, we can tuck the arm back at the side so that the C-arm can rotate around the table, and at the end, we can reabduct the arm to 90 degrees for the closure. Ultrasound guidance and micropuncture are essential. Shallow needle angle to access the axillary artery. It's the second portion of the artery where you can show that it's right against the backside of the pec minor. We use a stiff glide wire to support the devices as they're going in for pre-close. Again, the arm back out for access closure, and then we always maintain that wire access until we confirm that we have hemostasis by angiography before giving that up, and then that Ramel tourniquet technique can provide some improved hemostasis. Just to show you a little bit of the patterns of access that I've used for complex EVAR over the last 10 years or so before wrapping up. Here's a graph looking at my axillary artery access use. So you can see on the left-hand side, the green and the purple, that was open cut-down axillary access. Around 2017, we introduced percutaneous axillary access, so that's in the yellow and blue bars. And then in the red are cases where we didn't use any upper extremity access and went to entirely femoral approaches with steerable sheaths. So I started when I was in New York. Our volumes have been a little bit higher at Penn. We had a little lull here during the COVID year, of course. And this is looking at just at percentage by year. You can see that early on it was open cut down for axillary access, oftentimes with conduits. Around 2017, we introduced the percutaneous axillary access. That became quickly about 90% of our cases. We started using steerable sheaths and eliminating some of the upper extremity access in 2021. And now you can see that about 80% of our cases or more are done from a femoral approach, and less than 20% have upper extremity access, but it's still important. So to summarize, completely percutaneous access for complex EVAR is safe and effective. Upper extremity access does increase the stroke risk. So when we can do things from the groin, we will. Steerable sheath technology has really changed our practice, enabling us to do so many of these procedures from exclusively femoral access. But I do believe that selective use of axillary access remains an important and useful tool that we all need to be skilled at, because there are going to be some challenging iliac and femoral access cases, and when you need to use sequential deployment techniques for your procedure. Thank you very much.
Any questions from the audience?
Is there a go-to steerable sheath that you like to use? I've generally found that the tour guides that I use, they lose their kind of steerability after been in a place for a while.
Agree. The tour guides kind of suck, but that's what we use. That's why we support it with the 014 wire. If you support it with the 014 wire, it's very secure for that. But I agree. They can kink if you're in small spaces, and when we're doing FEVAR and not using the through wire, they can be a little bit of a challenge. There are probably some better steerable sheaths. I don't have a lot of experience with that, but just because we have these on the shelf and they're cheap, we're cheaper. They're not that cheap than some of the alternatives. We've stuck with them. There is going to be a new version of Tour Guide that's coming out, I think, right in the Q1 of 26, and it will address some of those concerns.
So you're saying you leave an 014 wire in while you're doing this?
Yeah, with the 8.5 French. So the Tour Guide, the 8 French Tour Guide is actually 8.5 French. So you have room to have the 014 wire supporting everything. And still be able to deliver 8 French devices through it. Now, fortunately, VBX, most of it's now lower profile and is now 7 French profile, so it actually goes very easily through that. But that gives you all the pushability and security that you need to be able to do downward going branches. So whether I'm doing stuff with the Cook platform stuff in my IDE or whether I'm doing TAMBI, that's still the same setup I use.
Yasan, from fellow from University of Chicago. Thank you for that great talk.
Sure.
I have a quick question about left-sided versus right-sided axillary access. I know there's a lot of paper in literature saying there's no difference in stroke rate, but just think about if coming from the right side, you're obviously crossing all the arch vessels. You would think that the stroke rate would be a little higher, but what's your experience with both sides? And
Yeah, so the ergonomics are a little better coming from the right. I still come from the left, and there are a couple reasons for that. From the right, it is a longer distance. There is more tortuosity when you're coming through the right side, through the innominate trunk as well. I've found that, and it's anecdotal, I have to look at the exact numbers, but at least in my mind, I have more percutaneous axillary access failures coming from the right side. There's just something different with the anatomy. Compared to the left. So the left, we've got it down, and that's just the routine that I've stuck with. But it makes it a little bit more challenging ergonomically. So if you're standing at the right groin and then the left arm is accessed, you can't really reach over and be working at both sites. It does help, though. I can tuck the arm back at the side and a lot of times bring the sheath down along the side, and so I can access that from standing at the right groin. But I still use the left side.
thank you.
Dan.
So is there a luminal size of the aorta in which you think using femoral access is not beneficial? In other words, when you do femoral access, you have to deploy the graft completely without through wires through any of the branches. And is there a luminal size that makes that, that eliminates or reduces your success rate in doing that?
Yeah, so I think that's a really good point, and it also goes into the selection between branches and fenestration. So I rarely will use branches if the luminal diameter is less than 25. I know that TAMBI on the IFU says 20, and I argued with them for a long time that was too small, and I think that's why they have some renal issues that they may be showing now, because there's just not enough room and competition between the branches and the device. It's not always so much the luminal diameter, but it has to do with whether or not there's angulation or tortuosity, because your graft's going to be biased towards one side. And then also, the targets that you're trying to access if you have, stenotic disease targets. And then, that may be easier to give yourself more working room and to do it from above. And then the other thing is when you're revising failed prior EVAR devices, specifically with struts across the renals. I think it's helpful to do the stage deployment because it just leaves you more room to navigate all that stuff. And that's about, a quarter of our cases are treating failed EVARs now.
Any other questions?
Right.
If not, thank you very much for the talk.
Thank you.
Let's move right into the next session. If Dr. Eck and Dr. Claire can come over to the moderator's table. So this session will be the last until we go to the competition. So this is a miscellaneous topics panel discussion, and we're going to start with Dr. Stern from Cornell. He's associate professor there and director of the vascular research endeavors. He's going to speak on spinal cord drains. Is there ever a need for prophylactic placement?
All right, we skipped the break and first talk also, so it looks like we're way ahead of schedule, so I guess I can drone on for 40, 45 minutes. Jordan Stern from Cornell, thanks for the invitation. We'll talk a little bit about spinal cord drains. We talked about dissections this morning and the paralysis risk, and I realized that there's like so much to cover in this talk, so this is generally kind of geared towards aneurysms, but we will kind of touch on it a little bit. Relevant disclosures. So spinal cord ischemia is probably the most feared complication, certainly the most devastating in many ways, of both open and endovascular aortic aneurysm repair. The literature will tell you that the rates are somewhere between 8 and 15%. That's based on a meta-analysis from a few years ago. I think in contemporary practice at high-volume centers, it's a little bit lower, thankfully, but it's still a real thing that happens. And what we're really talking about here is when the spinal cord perfusion is interrupted in endo cases by placement of a stent graft across the segmental, intercostal, and lumbar arteries. The most common presentation is an anterior cord syndrome. As you might imagine, these lumbars come off to the anterior spine, and that is motor deficit, whether it's partial paraparesis or full paraplegia, loss of temperature and pain sensation, and often loss of bowel and bladder control. Posterior effects such as proprioception generally preserved, although posterior symptoms can occur in larger infarcts. And the severity can range from just a minor deficit to dense paraplegia. Again, this is due to interruption of the intercostal and lumbar arteries that are segmentally located along the course of the aorta by your stent graft. And that's the primary etiology, although there's some other contributing perioperative factors such as systemic hypotension during the case or significant blood loss that can sort of contribute in patients that have a marginal perfusion status. Embolic phenomena as well. I've unfortunately had this happen from a shaggy aorta. But really, again, it's due to collateral circulation, and that includes both direct pathways and indirect pathways to the spinal cord. So these are the kind of factors we think of that are the most relevant, both the length of coverage, and again, that's more of a direct effect, patency of significant collateral pathways to the spinal cord, so through the hypogastric and the subclavian vertebral pathways, and then the presence of prior aortic surgery, which has already eliminated some of your intercostals and lumbars, for example, and that's both open and endo. So in order to understand this, we need to talk a little bit about the physiology of the spinal cord, and this is akin to what we see in the brain that everybody learns in medical school, but the spinal perfusion pressure is essentially the difference between your mean arterial circulating pressure and the intrathecal pressure. So in cases of marginal perfusion, we can augment the spinal perfusion pressure by either upping the MAP or decreasing the intraspinal pressure. We do this with the use of a drain. It's placed into the intrathecal space to drain CSF, and the goal is, again, to decrease the intraspinal pressure, thereby increasing the perfusion pressure in conjunction with MAP augmentation. So the benefits and risks of spinal drainage. The prophylactic use of the spinal drain, you can imagine, is that you can prevent a watershed infarct in a patient who's at risk by minimizing that intraspinal pressure before the insult actually occurs. It was for a long time routine practice in open repair, and that translated to the early endovascular experience for thoracoabdominal aneurysms and thoracic pathologies. And in 2010, the AHA and ACC actually recommended this universally for all open and endovascular procedures. Now, I think over time, we've seen that there is somewhat unclear benefit. It's not definite that these drains prevent issues from happening. And there are risks associated with the drain itself, which we're going to go into in some more detail. And so these ideas of selective drainage and rescue drainage were introduced. So what are the risks? The risk of drainflation is certainly not trivial. It can lead to significant morbidity itself. We're talking about things like spinal hematomas that can need OR decompression and can lead to paraplegia itself, intracranial hemorrhages, meningitis, CSF leaks that can require other procedures like blood patches. There are less severe issues also. The catheter can break off that might require somebody to go in there and fish it out. I've seen that. Non-functioning drains, and something we don't often think about is that your case actually might get canceled if this tap is a little bit bloody and you feel sort of hesitant to give systemic anticoagulation. This is a meta-analysis that looked at drain risks over time, 6 studies, over 1,000 patients undergoing branched and fenestrated repairs, and they found that the mortality actually related to the drain itself was 1.5%, so that is a real number, and 25% morbidity, including major complications like intracranial hemorrhage and spinal hematoma. You can probably tell from my tone where I'm going with my recommendations here. But again, and a pooled estimate of 10%, 11% non-functioning drains, so in 1 out of 10 patients, they don't even work. So what is selective drainage then? I mean, I think this makes some intuitive sense. If there's risk involved, then you need to identify those patients who are at highest risk of SCI so that you can drain those patients, but not necessarily everybody. And so the high risk factors that I think are generally kind of accepted would be long coverage, and that's somewhere 15 to 20 centimeters or greater, coverage in a high risk area, so just above the celiac, preoperative occlusions of the hypogastrics and or subclavian vertebrals, previous aortic surgery, and history of a previous spinal cord injury, for example, in cases of staged repairs. And the most important thing about selective drainage is that if you do not have a drain in the patient, you need to have the ability to rescue that patient by placing a drain postoperatively. So let's talk about rescue drainage. So this is predicated on the concept that a SCI is potentially reversible if caught early. And that's not always the case, but there are many cases where the SCI is actually rescuable. But the key here is that this must be quick. This cannot be a drain 6 hours later, because by then the infarct is set in, and those delays can certainly lead to permanent sequelae. This is a VQI study that looked at 3,000 TVARs over time and complex EVARs over time that found the SCI rate actually decreased over time, but they found worse neurologic outcomes and worse survival with patients who needed a rescue drain versus those who had an SCI where the drain was placed preoperatively. So it's not quite as good potentially. In the ARC, the use of prophylactic strains has decreased dramatically from 100% when it was first started in 2011 to only about 10 or 11% in 2023. And despite this, their spinal cord rate in this group has actually decreased quite a bit from 25 to 3%. So the concept must work in some way. This is another review, 900 TVARs performed in a lot of patients there with an overall SCI rate of 7.8%, and in this patient, rescue drains were needed in 35%. Importantly, they found that when the rescue drain went in, the SCI symptoms were either improved or resolved completely in nearly 70% of patients. So again, this sort of proves the concept that rescue drainage works. They had a low rate of permanent paraplegia, so you can see if the overall rate is 7.8 of SCI and the permanent paraplegia rate is 1.5%, then we're actually rescuing quite a number of patients. But it is important to note in these studies that in general, from what they could tell, most of the drains were placed very quickly, within an hour. So there's a randomized trial happening now. I think this is an important data point that's going to occur. This is an initial study of 20 patients that were undergoing fenestrated and branched EVAR for thoracic aneurysms, thoracoabdominal aneurysms. They noted 2 out of 20 patients had significant complications. One was an epidural hematoma that required laminectomy, and one SCI event that was actually somewhat later and related to hypotension. But again, underscoring the fact that these things do happen no matter what you're doing, even in high volume centers. And it shows the feasibility of a randomized controlled trial, which is now accruing patients, and I think this will give us some important answers. One thing that is very clear is that whether you're doing this prophylactically or as a rescue protocol, having a pre-established protocol in your institution is key, and that will definitely reduce your spinal cord risk overall. And that is whether you're doing image or landmark guided anesthesia or neurosurgery putting in your drains. It doesn't really matter as long as they do it well, and you can have a sort of protocol with open communication to understand these things. Training your house staff, nursing, everybody that is involved in the patient's care to recognize ICU, SCI issues, recognize drain complications early. That will help you have better outcomes as well. And of course, staging is a strategy that I just didn't have time to get into today, but we know that will reduce SCI risk as well. And this is probably the most important point. If you're going to employ a rescue strategy, as I've sort of alluded to a couple times, you just absolutely need to have the ability to put a rescue drain in within an hour. So what are the current recommendations? I would say there is a role for prophylactic drainage in high-risk patients and in those institutions without the ability to rescue. And so I came up with this schematic because I too like flow diagrams. And so if you're doing TVARs or fenestrated branch devices for thoracoabdominal thoracic pathologies where you think there's a risk of SCI, first question you need to ask yourself is, does your institution have the ability to rescue this patient? And if the answer is no, I think you should be placing prophylactic drains the night before, the day before, maybe the morning of, but making sure there's no bloody tap and making sure that patient is as protected as they can be. If you do have the ability, then I think you can employ a selective strategy. And the first question you then need to ask is this patient high risk? If they're high risk, so I would say coverage over 20 centimeters, some people are a little more conservative than that, previous aortic surgery, occluded hypogastric. Personally, every SCI I've ever seen had an occluded hypogastric. And so that to me is probably the most important factor, just based on personal experience, and previous SCIs. If they don't meet any of those high risk criteria, I think you can go with a rescue drain strategy, and then you just kind of need to employ these intra and post-operative mitigation strategies, keeping the map up, having a way to monitor with NIRS and things like that, considering perfusion branches if you do see a problem intraoperatively, and then post-operatively, again, just the ability to recognize and diagnose problems quickly. So that's all I have. Thanks very much.